Well, good morning, everyone. It's a pleasure to be here, and it's nice to see some familiar faces in the audience. I've been the LTCH CARE lead at RTI for about 2.5 years now, and I continue to enjoy coming to these training sessions as my own knowledge increases as I get more experience. Having had an acute care background, it was a natural transition for me to move to LTCH. Okay, so the next two slides are the acronyms that will be very familiar to all of you in the room. One of the things I wanted to ask is how many of you are experienced in using the LCDS versus me asking you how many are new to using it, because I don't want to spot that. So the majority of you are experienced? Okay. So in this session, we'll talk about Section I, the active diagnosis. We'll talk about the intent of it. We're going to describe the new items or changes between version 3.0 and 4.0. And as you're going to see, there's a lot of changes related to the ventilator liberation quality measures, which I'll be talking about later this afternoon. As in previous presentations, we'll be discussing coding instructions, and we'll have the opportunity to do some practice scenarios. So the objectives of this session are to state the intent, and at the end of the presentation, you should be able to articulate the purpose of each of these items and coding options for each of the existing, revised, and new items, and then apply coding instructions to accurately code clinical scenarios. The intent of items in Section 1 are intended to indicate the presence of selected diagnoses that influence a patient's functional outcomes, a patient's ventilation liberation outcome, and or influence the patient's risk for the development or worsening of pressure ulcers. As we all know, a patient's disease processes and conditions can significantly affect a patient's health status and quality of life. And this particular section serves to identify the active diseases and conditions that are associated with the patient's LTCH stay. In the next two slides, I will review changes between LCDS version 3.0 and 4.0. This slide shows the new items. I'm not going to go into them in great deal at this time because I'll be covering them in more detail this afternoon. But these have been expanded because they are risk factors or risk adjusters that will be used to calculate the two new ventilator liberation measures. I will briefly draw your attention to the new items, which are I06050, severe left systolic ventricular dysfunction, which was identified by the ventilator liberation technical expert panel as a potential risk factor for patients on a ventilator. You'll also note that there are 3 additional neurologic-based risk factors that are also added to this section. Again, this was feedback and input from our technical expert panel that developed the quality measures for ventilation liberation. The remaining items are associated with organ transplants. Again, these are risk factors for the ventilation liberation measures. And a point of emphasis I want to make about the transplant items is that they are to be used for patients that have received a transplant. So they're not to be used if the patient is in your facility waiting a heart transplant or a renal transplant. The next slide provides detail on the change of metastatic and severe cancer. So you may ask, why did we go from severe and metastatic cancer as one data element to these two data elements? And the response to that is, again, there was input from the technical expert panel that developed the ventilator quality measures for liberation, And it was felt that they are different types of patients. So as most of you know, a patient with metastatic cancer will have a primary diagnosis, say, of lung cancer, and that may metastasize to the bone or the brain. So that's an example of a metastatic cancer. A severe cancer, using that same example, might be but the patient has lung cancer that has not metastasized. And I think one of my suggestions that may help in terms of differentiating the severe cancer from the metastatic is to turn to your ICD-10 codes. So for instance, the ICD code C35.11 is lung cancer, malignant neoplasm of upper lobe, right bronchus, or lung. An example of a metastatic ICD-10 code would be C79.31, which is a secondary malignant neoplasm of the brain. And I'm not a coding expert. You probably are much more adept at this. But it would be my understanding that you would use these codes for the example that I've given. So in the next section, we'll talk about coding diagnosis, these active diagnoses. This definition is familiar to all of you and has not changed. An important component of completing Section I is identifying the patient's primary medical diagnosis and determining if they are active. Active diagnoses are those diagnoses that have a direct relationship to the patient's current functional, cognitive, mood, or behavior status, medical treatments, nurse monitoring, or risk of death at the time of assessment. Diseases or conditions that have been resolved at the time of the assessment or do not affect any of the patient factors listed above should not be included. This is the data element for indicating the patient's primary medical condition. And the four primary conditions are acute onset respiratory condition, chronic respiratory conditions such as COPD, acute onset and chronic respiratory conditions, and a chronic cardiac condition like heart failure. You're going to enter the code of the primary medical condition. You're going to indicate 5 if the patient has a primary medical condition that is not on one of the conditions 1 through 4. So an example might be complete tetraplegia. If your patient has one of these 4 primary diagnoses, you would use those numbers to indicate it. You would not put, say, acute onset of respiratory condition in 5 and put an ICD-10 code there. If your patient has one of these 4 conditions, you're going to code them as such. The rationale for this particular data element is that it captures the patient's primary medical category that resulted in the patient's admission to the LTCH. The first step in the assessment is to identify the primary medical condition as shown as the previous slide. The diseases and conditions in this section require a physician or nurse practitioner, physician assistant, clinical nurse specialist, or other authorized licensed staff if allowable under state licensure laws to document the diagnosis at the time of the assessment. The second step in the assessment process is to determine the patient's active diagnoses. As previously stated, active diagnoses are diagnoses that have a direct relationship to the patient's current functional cognitive mood or behavior status, their medical treatments, nurse monitoring, or risk of death at the time of assessment. Patient's diagnosis may be found in any combination of medical record sources, such as problem lists, physician orders, history, and physical. Although open communication regarding diagnostic information between the physician and other clinical staff is important, it is also essential that the diagnosis communicated verbally be documented in the medical record by the physician or their designee. Diagnostic information, including past medical and surgical history obtained from family members and close contacts, must also be documented in the medical record by the aforementioned providers to ensure validity, follow-up, and coordination of care. Only diagnosis confirmed and documented by the physician or their designee should be considered when coding this section. This slide reviews the primary medical condition categories as previously described. If the patient's primary medical condition does not fit one of these categories, as I've already indicated, then indicate the primary medical condition in number 5 and enter the ICD code. Once you have entered the patient's primary medical condition, you're going to proceed to comorbidities and coexisting conditions. So we'll start with a few, we'll now go to some coding scenarios. Mrs. K is a 67-year-old female who is admitted to the LTCH after an acute episode of respiratory failure secondary to pneumonia. Mrs. K is on invasive mechanical ventilation. The admission diagnosis of an acute episode of respiratory failure secondary to pneumonia is documented in the progress notes of the patient's medical record by the LTCH admitting physician. How would you code this particular scenario? Code 1, acute onset respiratory condition. 2, chronic respiratory condition. 3, acute onset and chronic respiratory conditions. Or 4, chronic cardiac condition. And I can see that the majority, 100% of you have elected code 1, acute onset respiratory condition. And that is correct. And you entered this correctly because this is the patient's primary condition category, and it was documented by the physician in the progress notes as the reason for the patient's admission to the LTCH. The next 3 slides depict the multiple categories of the comorbidities and coexisting conditions component of Section I. If a patient has any of these conditions, the person completing the data set should check all that apply. This section is completed only if A, 250, reason for the admission, equals 01, admission. You should code diseases or conditions that have a documented diagnosis at the time of the assessment and are active and, as previously stated, have a direct relationship to the patient's current functional, cognitive, or mood or behavior status, medical treatments, nurse monitoring, or at risk of death at the time of assessment. The expanded list of comorbidities and coexisting conditions comprise cancers, heart circulation, genitourinary infections, metabolic, and musculoskeletal, as well as neurologic. And this section has been expanded. A couple of examples of that are I-5455, other progressive neuromuscular disease, and I-5480, other severe neurological injury, disease, or dysfunction. And again, these were added for the ventilator liberation quality measures. Nutritional is all familiar to you and has not changed. And then, as I've already mentioned, we have a new section called post-transplant, and we've included lung, heart, liver, kidney, and bone marrow transplant. Again, you would only check these if your patient has received one of these transplants. You would not check it if your patient is awaiting a transplant. And if your patient has none of these active diagnoses, then you're going to check off a Z. This slide just depicts the changes in terms of the categories from 3.0 to 4.0. We have 9 categories representing 32 diagnoses and a place to indicate that none of the above apply if the patient's being assessed. The comorbidities and coexisting conditions, item rationale, they, as previously stated, they capture the patient's comorbidities and coexisting conditions. And as you know, disease processes can have a significant adverse effect on an individual's health status and quality of life, and these disease processes and conditions can influence a patient's health outcomes. To identify the comorbidities and coexisting conditions, the first step you're going to do is identify the diagnosis by reviewing the medical record to determine the patient's active diagnosis. You're going to determine whether the diagnoses are active. Once a diagnosis is identified, you're going to determine whether the diagnosis is active. There must be specific documentation, as I've already indicated, in the medical record by a physician or designee or condition being an active diagnosis. The physician or designee may specifically indicate that a diagnosis is active. Specific documentation areas in the medical record may include, but are not limited to, the previously mentioned sources of documentation. The physician or designee, for example, documents at the time of the assessment that the patient has inadequately controlled diabetes and requires adjustment of the medication regimen. This would be sufficient documentation of an active diagnosis and would require no additional confirmation because the physician documented the diagnosis and also confirmed the medication regimen needed to be modified. For the purpose of the LTCH CARE Data Set, LTCH should consider only the documented active diagnosis. A diagnosis should not be inferred by association with another condition. So for instance, weight loss should not be referred to or inferred to mean malnutrition. This slide summarizes all of the comorbidities and coexisting conditions on the new LTCH CARE Data Set version 4.0. And I'll just go over a few of these. So for the, you're going to check I-0101 cancer if the patient has metastatic cancer, such as an acute leukemia, lung cancer, multiple myeloma, and lymphoma. You're going to check I-0605 if the patient has severe left systolic ventricular dysfunction. And important to understand about this coexisting condition is that the severe left systolic ventricular dysfunction is defined by the patient's ejection fraction. So you would code this item if the patient's ejection fraction is less than or equal to 30%. You'll check I-0900 heart circulation if the patient has peripheral vascular disease or peripheral artery disease. You will check the infection category if the patient has a diagnosis of septicemia, sepsis, or systemic inflammatory response syndrome shock. You might check stroke if the patient had, an example might be diagnosis of cerebral hemorrhage or late effects of cerebral vascular disease. You would check I-5000 paraplegia if the patient had a fracture, say at T1 to T6 level with complete lesion of the spinal cord, fracture of T7 to T12 level with complete lesion of spinal cord. And those are just a few examples. Okay, now we'll go on to coding scenarios. Mr. F is admitted to the LTCH for medication administration, pulmonary assessment, and speech language pathology therapy post-hospitalization for aspiration pneumonia due to dysphagia. Included in the patient's history and physical assessment is the diagnosis of Shy-Drager disease, which means multiple system atrophy. How would you code I-0050? 1, acute onset respiratory condition. 2, chronic respiratory condition. 3, acute onset and chronic respiratory condition. Or 4, chronic cardiac condition. And the correct answer is A, acute onset respiratory condition. I think we're going to have to do something with our training because this one, people tend to have a little difficulty with this one. In the next scenario, I'm going to ask you, or as part of this scenario, I should say, we're going to ask you to check off which comorbidity and coexisting condition would you check. So your responses are diabetes mellitus, A, stroke, B, other progressive neuromuscular disease, C, and D, none of the above. And we did very well there. And C is the correct response, other progressive neuromuscular disease. In this scenario, the patient's primary condition category is acute onset respiratory condition, and the coexisting condition is an other progressive neuromuscular disease. So I, 54, 55 would be check. So let's do another scenario. In this scenario, Mrs. P is admitted to the LTCH after a bone marrow transplant. The hospital transfer record includes a signed discharge summary with a list of diagnoses, including aplastic anemia and allogeneic bone marrow transplant. She is receiving medication and is being monitored for signs and symptoms of transplant rejection and infection. How would you code this comorbidity and coexisting condition? And C, bone marrow transplant, is the correct answer. And this is correct because she was admitted to the LTCH post-bone marrow transplant. She is receiving medical treatments related to the bone marrow transplant, and the hospital's transfer record includes a signed discharge summary documenting this diagnosis. In the next scenario, we have a patient had a surgical removal of a spinal cord tumor at the level of T6 and a diagnosis of complete paraplegia. The physician's progress note documents the diagnosis of malignancy and the need for further treatment with chemotherapy and radiation. Which comorbidities and coexisting conditions would you check? A, metastatic cancer, B, severe cancer, C, paraplegia, D, both metastatic and paraplegia, or E, both severe cancer and paraplegia. People are making some decisions about this response, being back and forth. So the correct answer in this situation, in this scenario, would be E, both B and C. So you would check severe cancer, I-0104, and I-500 paraplegia, as these are both considered active diagnoses for the patient, as both were documented in the physician's progress notes. The next scenario is number 5, and the patient is admitted to the LTCH after a stroke. The admitting physician has reviewed the record of the hospital course and performed and documented the history and physical indicating the stroke occurred in the postoperative period following a kidney transplant. He also writes the patient is receiving parenteral nutrition as he is at risk for malnutrition. The patient has right-sided hemiparesis and neglect identified in the transfer report from the hospital. Which comorbidities and coexisting conditions would you check? A, stroke, B, hemiplegia or hemiparesis, C, at risk for malnutrition, D, kidney transplant, E, all of the above. And you answered correctly faster than I even got the responses out. And that is the correct response. And you would code the stroke, hemiparesis, and as at risk for malnutrition due to neglect in a status post a kidney transplant. The patient's functional status, medical treatments, and monitoring requirements are directly related to the diagnosis of stroke with right-sided hemiparesis and post-kidney transplant. All of these diagnoses are documented by the physician in the patient's medical record. In our last scenario, we have Mr. B, who is admitted to the LTCH with the diagnosis of status post-heart transplant for severe cardiomyopathy and end-stage heart failure. The hospital discharge record includes an extensive cardiologist report which documents an echocardiogram result of an ejection fraction of 15%, a diagnosis of severe left systolic dysfunction, and a long history of cardiomyopathy with end-stage heart failure. The signed heart transplant surgical report is also included in the hospital transfer note. Nursing care includes cardiopulmonary monitoring as well as post-transplant assessment. So how would you code I0050 in this scenario? A, acute onset respiratory condition, chronic respiratory condition, C, onset and chronic respiratory conditions, or D, chronic cardiac conditions. And again, you've responded 100%. D, chronic cardiac condition, excuse me, I'm ahead of myself. So it would be D, chronic cardiac condition. I'm running out of time, so I'm moving fast. So in this scenario, which conditions and comorbidities and coexisting conditions would you check? A, severe left systolic ventricular dysfunction, B, heart transplant, C, none of the above, or D, both A and B. And that is correct. And this is correct because there was documentation in the patient's medical record that he had a chronic cardiac condition, heart failure, with status post a cardiac transplant, had an ejection fraction of 15%, which meets the criteria for severe left systolic ventricular dysfunction. So in summary, I have reviewed all of Section I. I've provided the new data elements that were added to this section, many of which are added because of the because of the ventilator liberation outcomes. And in terms of your action plan, similar to what my colleagues have indicated, you want to review Section I with your staff in its entirety with an emphasis on the steps for assessment, including identification of the patient's primary medical condition and comorbidities and coexisting condition. You want to reinforce the importance of documenting and what the required documentation in the medical record, and using only documented comorbidities and coexisting conditions to complete this section. I'd also suggest that you reinforce with your staff not to infer a diagnosis from documentation that is not consistent with a specific diagnosis. And this ends the presentation for Section I. So please submit any questions that you have about Section I. And now we are breaking for lunch.